Welcome to the deep dive. Today we're venturing pretty deep inside the body, actually. We're looking at arterial blood gases, ABGs.
Right, ABGs. Sounds technical maybe, but it's really just a snapshot. A vital one, though.
Yeah, like a chemical picture of what's happening, balancing acts and all that.
Exactly. And our mission here, our deep dive goal is to help you understand what an ABG report is saying, how it shows acid-base balance, oxygen levels, how the lungs are working.
We'll break it down step by step. No need to feel intimidated.
Not at all.
Yes,
So there are these four main things we look at in an ABG.
Okay, first is pH, right?
Hmm.
Acidity or alkalinity. The body likes it really specific.
Super specific. That range is tiny, 7.35 to 7.45. Anything outside that, well, it flags a problem.
Then there's PECO. That's carbon dioxide pressure. Tells you about breathing out to air.
Precisely. Normal is 35 to 45 millimillar Hg, shows lung ventilation efficiency.
Got it. And PEORO, that's oxygen.
Yep, oxygen pressure in the arteries, how well oxygen gets from lungs to blood. You want that around 75 to 100 millimeters Hg generally.
Okay, and the last one, HCO₃.
Bicarbonate, yeah. HCO, that's more about the kidneys and their role in that acid-base balance. Normal's about 22 to 26 MEQL.
So why should you, our listener, care about these numbers, even if you're not in medicine?
Well, it's fundamental, isn't it? It's about how your body keeps itself stable, that internal equilibrium.
Right, seeing how just breathing affects blood chemistry. It's kind of cool when you think about it.
And when things do go wrong, maybe lung problems like COPD or serious diabetes issues, big infections like sepsis, these ABGs are critical. They tell doctors what's really happening.
Like in respiratory failure, shock, even some poisonings, ABGs are key.
Indispensable, really. For diagnosis, for guiding treatment, it's that direct window.
So let's dig into that core idea, acid-base balance, that narrow pH window, 7.35 to 7.45. The body works hard to stay there.
It really does. It's incredibly sensitive. Tiny shifts can mean big trouble.
And how does it manage that? You mentioned two main systems.
Yeah, two key players. First, the lungs. They're the rapid responders. Control CUROs by how fast or slow you breathe. Breathe faster, less CoAero acid. Slower, more QO acid builds up.
Okay, lungs are fast. What's the other one?
The kidneys, they manage the bicarbonate levels, but they're slower, more deliberate. It takes hours, even days for kidney adjustments to really show. Got it.
Fast lungs, slow kidneys, working together for balance.
Usually. But when one system falters or gets overwhelmed, that's when you see these acid-based disorders pop up.
Right. And there are four main types we should probably outline.
Exactly. Let's start with respiratory acidosis. Think about, say, that COPD patient example. Lungs aren't blowing off enough QO.
So CoAeros builds up.
Right. CO acts like an acid in the blood, so more QO means the blood gets more acidic. pH drops below 7.35. That's respiratory acidosis.
Okay, then the opposite must be respiratory alkalosis.
You got it. Think panic attack, hyperventilating, breathing way too fast.
Blowing off too much QR.
Exactly. Less CoAero acid means the blood becomes more alkaline. pH goes up above 7.45.
Makes sense? Now the metabolic side.
Okay, metabolic acidosis. This happens if you lose too much bicarbonate, maybe from something like severe diarrhea, or if your body produces too much acid, like ketones and diabetic ketoacidosis.
So either losing base or gaining acid. Either way, pH drops.
Correct. pH goes below 7.35 again, but the cause is metabolic, not breathing-related initially.
And the last one, metabolic alkalosis.
This is when you have too much bicarbonate or you've lost too much acid. The classic example is like prolonged vomiting, losing all that stomach acid.
So the blood gets too alkaline, pH goes above 7.45 because of a metabolic reason.
Perfect. Those are the four main disturbances, but
Yeah.
the body doesn't just sit there.
Right. Compensation. The other system tries to help out.
Exactly. It's this amazing backup system. If the lungs are the problem, the kidneys try to fix it. If the kidneys are the problem, the lungs jump in.
Okay, walk me through that. Say respiratory acidosis, lungs aren't working well, QO is high, pH is low. What does the kidneys do?
The kidneys, being the slower responders, will start to hang on to more bicarbonate. Bicarb is alkaline, remember? So by increasing bicarb, they try to neutralize that extra acid from the theoro and pull the pH back up towards normal.
Okay, kidneys add base to fight the respiratory acid, and the other way around. Metabolic acidosis, maybe low bicarb, low pH. What can the lungs do?
The lungs react much faster here. They'll increase breathing rate and depth, hyperventilate, essentially.
To blow off more CO.
Yeah, precisely. Blowing off that CoAero acid helps counteract the low bicarbonate, trying to raise the pH back towards that normal range. It's a really neat interplay.
But it doesn't always get it perfectly back to normal, does it? You mentioned partial and full compensation.
Good point. Yeah, sometimes the compensating system can only do so much. If the pH gets all the way back into the normal 7.35, 7.45 range,
Yeah.
even though the original problem, like high HCO or low bicarb, is still there, we call that full compensation.
Okay, pH is normal, but the other numbers are still off, showing the fight.
Exactly. If the pH moves towards normal but doesn't quite reach it, that's partial compensation. The body's trying, but hasn't fully corrected it yet.
And if nothing's happened yet.
Then we say no compensation. Maybe it's too acute. The compensating system hasn't had time to kick in significantly.
Okay, this is starting to form a clearer picture. So how do we actually use this when we see an ABG report? You had that 4-step approach.
Yes, a systematic way makes it much less daunting. Step 1, check the pH. Simple. Is it low? 7.35, acidosis, high, 7.45 alkalosis, or normal? That's your first clue.
pH first. Acid, base, or normal. Got it. Step 2.
Step 2, find the primary disorder. Is it the lungs or the metabolism causing that pH change? Here's the trick. Look at pH and PACO. If they move in opposite directions, like pH down, PACO up, think respiratory.
Yeah, opposite respiratory.
And then look at pH and bicarbonate, HCO₃. If they move in the same direction, like pH down, bicarb down, think metabolic.
Same direction. Metabolic. Opposite respiratory. Okay, that helps narrow down. What's step 3?
Step 3, look for compensation. Now you check the other value, the one not causing the primary problem, to see if it's trying to help. If it's respiratory acidosis, high CO, is the bicarb starting to go up? If it's metabolic acidosis, low bicarb, is the key O starting to go down because of faster breathing?
So checking if the backup system is actually doing anything.
Pretty much. You're seeing if that expected compensatory change is happening. Again, is it partial, full, or none?
Right. And the final step, step 4.
Step 4, check oxygenation. Just look at the POCO. Is it below the normal threshold, usually around 75 mg? If yes, the patient has hypoxemia, low oxygen in the arterial blood.
Okay. pH, primary rest metab, compensation, oxygenation, that seems manageable.
It really is once you practice it a few times.
Let's try. Let's apply it. You mentioned a COPD patient earlier. 65-year-old, short of breath. ABGs were pH 7.29, PACO instios, bicarb 28, PAO 65.
Okay, perfect. Let's walk through it. Step 1.
pH 7.29, that's low, so acidosis.
Good. Step 2, primary cause.
Okay, pH is low, acid, PACO's high, 60, opposite directions. That points to respiratory. Primary respiratory acidosis.
Excellent. Step 3, compensation. We look at the bicarb.
Bicarb is 28, normal is 22-26, so it's a bit high. The kidneys are trying to compensate by holding on to base, but the pH isn't normal yet, so partial compensation.
Exactly right. Partial metabolic compensation. And step 4.
Oxygenation. PO is 65, normal is 75-100. So that's low. Hypoxemia.
Perfect. So putting it all together, acute respiratory acidosis with partial metabolic compensation and hypoxemia fits that COPD exacerbation picture perfectly. Treatment, likely oxygen, maybe help with breathing like BiPAP.
See, that really works. Okay, example 2. A 30-year-old with diabetes, breathing fast.
10.
ABGs. pH 7.24, bicarb 10, bicarb 95.
All right, step 1, pH.
7.20. Low again. Acidosis.
Step 2, primary. pH is low.
Let's check bicarb. It's 10. Super low. Normal's 22-26, so low pH, low bicarb. Same direction, that means metabolic. Primary metabolic acidosis.
You're getting this. Okay, step 3, compensation. Look at the PICA.
PACO's is 24. Normal's 35-45, so it's low. The lungs are blowing off SOCO to try and fight the acid, but pH is still low, so partial respiratory compensation.
Spot on. Partial respiratory compensation. And step 4, oxygen.
PO is 95. That's well within normal. No hypoxemia here.
Great. So the full interpretation: metabolic acidosis with partial respiratory hypertension and normal oxygenation. Classic diabetic ketoacidosis, DKA. Needs insulin fluids.
This framework really makes sense.
Perfect.
Last one, the 25-year-old hyperventilating from a panic attack, ABGs. pH 7.50, PACO 28, bicarb 22, PAO 100.
Let's do it. Step 1.
pH 7.50, that's high. Alkalosis.
Step 2. Primary cause.
pH is high. PACO's 28. Normal's 35-45, so that's low. High pH, low PACOs, opposite directions. Respiratory. Primary respiratory alkalosis, caused by the hyperventilating.
Exactly. Step 3. Compensation. Check the bicarb.
Bicarb is 22. That's actually right at the low end of normal, 22-26. So the kidneys haven't really done anything yet. No compensation. Or maybe minimal.
Correct. It's too acute. The kidneys haven't had time. So we'd say no significant metabolic compensation. And step 4.
PROs is 100. Perfectly normal oxygen.
So the picture is acute respiratory alkalosis, uncompensated, with normal oxygenation. Management is about calming the patient down, maybe having them rebreathe Kieros.
Wow. Those examples really show how the numbers tell a story, especially with the 4 steps. It's not just random data.
Not at all. It's physiology in action.
Yeah.
But, and this is really important, you always have to put the ABG results together with what's actually going on with the patient.
Right. The clinical context, symptoms, history, exam findings. The ABG is one piece, a powerful piece, but still just one piece of the puzzle.
Couldn't have said it better myself. It guides you, confirms things, but doesn't replace looking at the whole patient.
So wrapping up this deep dive, we've seen ABGs are, well, pretty crucial for understanding that internal balancing act, acid base, oxygen breathing.
And we've broken down the main acid-base problems, the 2 respiratory, the 2 metabolics, and how the body tries to fight back with compensation.
And hopefully that 4-step method, pH, primary, compensation, oxygen, gives you a practical way to start making sense of these reports.
Definitely. It's a solid framework to begin with.
But the big takeaway, maybe, is what you just said. Always, always connect the numbers back to the actual person, the clinical situation.
Absolutely. That's where the true understanding lies.
It does make you think, though. Understanding this balance, even just the basics, how could that maybe help you understand health news better, or, maybe what a family member is going through medically?
It definitely gives you a different perspective, doesn't it, on just how finely tuned our bodies are and what happens when that balance gets disrupted.
Yeah, maybe just appreciating that complexity is valuable. If this has piqued your interest, maybe look up some practice ABG cases online. There are tons out there. It's a great way to practice that 4-step approach.
Good idea. Repetition really helps cement it.
Well, thanks for joining us on this deep dive into the world of ABGs.
Been a pleasure.